now listening to Protecting Your Nest with board-certified family medicine and obesity medicine specialist Dr. Tony Hampton. For more, visit drtonyhampton.com. Welcome to the Protecting Your Nest podcast. During previous episodes of the podcast, we've had a chance to talk about the benefits of using keto and intermittent fasting as a way to treat the second leading cause of death in the United States, and that's cancer. So if you've enjoyed any of those episodes with guests like Dr. Christy Castorine, who talked about keto for cancer, or Martha Tenenbaum, who focused on fasting used in conjunction with chemo, you've already gotten yourself a peek at what we're going to talk about today. Knowing that keto and intermittent fasting are lifestyle approaches that can positively impact cancer, may have sparked your curiosity about other lifestyle changes that can make a difference as it relates to cancer care. If that's a question you've been asking, today you will find some clarity, because today's guest has taken the time to consolidate with his team what the evidence is telling us about the best ways to treat cancer naturally and with the use of repurposed medications. Today's guest is Dr. Paul Marik. Dr. Marik is the co-founder of the Frontline COVID-19 Critical Care Alliance, which is an alliance of doctors and medical scientists from around the world that includes some of the most published researchers in their respective fields. Dr. Marik is a pioneer in medical research and former professor who also is the second most published critical care specialist in the world. His latest work, which is what we're going to walk through today, is an extensive review of the evidence on the use of repurposed medication in treating cancer, using the findings of over 800 peer-reviewed studies, which is very important to all of us. And they developed this monograph intended to educate physicians like myself and patients like many of you about the overlooked role repurposed medication, supplements, and lifestyle has on cancer treatment protocol. So unlike previous episodes of the podcast, we'll be doing this episode in more of a lecture style, where Professor Marik will share the slides that are available on the website we will be sharing in the link. So let's make sure that you check the link to the video and or to the podcast. So if you want to follow along and you're not watching this on YouTube, please feel free to do just like that. So before I share my screen, Doc, anything you'd like to say before we get started about, why in the heck did you decide to focus on helping people in the cancer space?
Yeah, so that's a good question. It happened somewhat by accident, and I was intrigued by the topic. And so, we've obviously developed an interest in the use of repurposed drugs to treat a whole host of diseases. And also we figured out how important metabolic control is, that insulin resistance, which is obesity, our modern lifestyle, our bad food, underlies so many diseases: heart disease, diabetes, atherosclerosis, chronic inflammatory diseases. So, that this is a way for people to empower themselves, to take control of their health. And, very simple interventions, because modern medicine has failed actually to control chronic disease. And as we know, and as we'll see in terms of cancer, chemotherapy has enormous limitations. And so there are viable alternatives which can often be used adjunctively together with conventional therapy.
And there's so many people who need this information. That's why I think it's going to be a valuable podcast. When you think about all the people who are at risk for cancer because of their family history or because of environmental factors, when you think about all the people who have family who has either dealt with cancer or dealing with cancer or maybe at risk for cancer, what a gift to give people, to say, you know what, your doctor's going to do their best, their due diligence to give you the best treatment plan they know of. But wouldn't it be wouldn't it be cool if you can do some of this yourself? So I'll share my screen so that we can put in front of our viewers today some of the slides that, again, will be available to everyone after our discussion. And let me go ahead and start by going to the conflicts of interest. And I'll let you kind of take it from here, Doc.
Yeah. So what you say is true. What we did is, this data is out there, but we went through the data, we synthesized it, we compiled it. So in a very reasonably concise format, people can get all the information. The references are provided, and it's all peer reviewed. None of this is being made up. So this is an important slide. I and we have no conflicts of interest, and that's really important, because when you have a conflict of interest, even a small conflict of interest, it biases your perception and it biases your recommendations and treatment. So we're not selling anything. We have no product. We're just providing information.
And I believe it, because everything is being given to us for free. The slides are on the site. I just really, again, appreciate that you are doing it that way. So let's look at this next slide.
Yeah, so what people don't recognize is that 1 in 3 people will develop cancer. Despite all the improvements in medical care, the risk of cancer is now 1 in 3. 1 in 3 people will develop cancer, and it will become the commonest cause of cancer. And so you can ask, why is the risk of cancer going up? And it's quite simple. It's the modern lifestyle. Part of it is environmental pollution and contaminants, but there's no question it's the modern lifestyle. It's the insulin resistance. It's the lack of vitamin D. Yeah. It's the lack of exercise. It's smoking. It's processed food. The consumption of processed food is a direct cause of cancer. The consumption of sugary drinks, the consumption of fruit juices, all of these contribute directly to cancer. And people need to understand that these are modifiable risk factors.
And what's interesting is a person may say, well, Doc, it's just my genes. And what I would say is there's something called epigenetics. So the things you eat, your environment, all of these things can affect your genes and the genes of your offspring and their offspring as well. So it all comes down to the same source, which is what we're doing to ourselves based on what the environment is doing and what we put in our mouth. So I think that's a very good point.
Yeah. And then, as we'll see, actually, genes do play a role, but cancer is actually not a genetic disease, as we'll come to.
Right.
And so that's an enormous paradigm change. So this is just a table showing the most common cancers in men and women. Basically, about 300,000 deaths expected this year. The most common in men: lung, bronchus, prostate, colorectal, pancreas, liver. In women, again, lung, breast, colorectal, pancreas, ovary. And the bottom line is that these are not chemo-responsive tumors. And so we will talk about chemo-responsive. These are tumors that cannot be, once they're metastatic, these tumors are not cured by cancer chemotherapy. And chemotherapy has a limited role in these diseases.
That's a very profound statement. Most people who think about cancer have assumed that chemo is the gold standard, but to hear you say that most of these tumors are not responsive to chemo only further emphasizes the need to come up with alternative approaches that may be more effective. So I definitely think that's a striking statement.
Yeah, and so this is the increase in the risk of melanoma. It's truly astonishing over the last 30 years, and the increase in non-melanoma skin cancer. Again, just highlighting that the risk of cancer is increasing, and people need to be proactive to reduce their risk of getting cancer. And there are simple things that they can do to reduce their risk. Yeah, so just a disclaimer, this is a review of published literature that patients should always discuss therapy with their physician before embarking on any treatment plan, that these interventions are used as adjuncts to conventional therapy, and that this is a living document. It's my understanding, and our understanding grows every day. And so, people should come back to the website and we'll be able to download a living document which is going to evolve with time.
And I would do the world a favor for anybody checking out this episode. If you know a hematology oncologist who may not be aware of this information, this may be a great podcast to share. Certainly, the website would be a great resource as well, because it's very likely that they may have not heard some of this information, and if they have, they may not know the impact that these lifestyle changes can make on a person's cancer.
So this slide outlines the traditional cancer treatment. Surgery, chemo, and radiation therapy basically are the cornerstones of therapy. But as I've said, basically for most patients with cancer, these therapies are limited. The one exception will be, and we'll discuss it then, those patients who have localized cancer. So if it's a stage 1 cancer localized to the organ, then you can get a good result with surgical excision. So the problem is conventional chemo and radiotherapy is significantly limited. And as we'll see, chemotherapy and only act on a rapidly dividing cell population, but cancers are made up of a very heterogeneous population. Only about 10% of the cells are actively dividing. So the chemo actually only targets a small percentage of the cancer, but it does also target other rapidly dividing cells, such as the patient's bone marrow, the GI tract. And so it does cause significant toxicity. It's not localized. Secondly, there's a thing called the cancer stem cell, which is just so important. And I really didn't understand it, and many patients may not understand how important the stem cell is. And the stem cell is the cell which gives rise to the cancer. And what happens with chemo actually doesn't kill the stem cell. It actually allows it to proliferate. So in a way, chemotherapy promotes metastases and proliferation of cancer, whereas all the repurposed drugs kill the cancer stem cells. So one has to target the cancer stem cells. Secondly, there's a thing called the tumor microenvironment. The cancer cells live in this environment which promotes their growth, and there's profound inflammation. And chemotherapy actually promotes inflammation in the microenvironment. It increases angiogenesis and it increases metastatic potential. So it's like a double-edged sword. While chemotherapy may kill the rapidly dividing cells, it actually does promote metastatic potential. And then, of course, it's highly toxic. Patients know this. The side effects are awful and very expensive.
I had never heard that only 10% of the cancer cells are actively dividing. In fact, because we've always been trained that cancer attacks the fast-growing cells, and or chemo does, but I thought all the cancer cells were fast-growing. So I think that's a pretty striking reality, to know that you have these other cells, like the stem cells, that are also part of the equation that we're just ignoring. So this is pretty profound.
And then we need to get back to the conventional theory of cancer, which we're going to talk about. And so the conventional theory, which is basically propagated by all oncologists and almost all of the cancer society, is that cancer is a genetic disease. It's caused by a genetic mutation, and then this drives a population of cells that have gene mutations, and that these cells then have the following properties: that they sustain proliferative signaling, they have growth suppressors, they resist cell death, they have immortality, they induce angiogenesis. And so this is the conventional theory of cancer, that it's basically a genetic disease, and due to a mutation which changes the biological property of the cell. But as we'll see, there's more and more data to suggest that this theory is in fact wrong. Yeah. So the inference is that if the premise on which your treatment is based is wrong, then obviously your treatment can't be correct. So the implications of this concept are enormously far-reaching.
Wow.
And so to understand what we consider to be one of the most important causes of cancer, which is a metabolic disease. So we consider cancer a metabolic disease rather than a genetic disease. And we have to go back to 1924, when Otto Warburg, who was a biologist and received the Nobel Prize for his work, he basically discovered this phenomenon in all cancer cells. And I need to emphasize this. This is all cancer cells, solid cells, hematological cells. It doesn't matter what the cancer is, that all cancer cells have an abnormality of aerobic metabolism. Their mitochondria cannot use oxygen. They have defective mitochondria, and they undergo anaerobic glycolysis, even in the presence of oxygen. And so tumor cells, unlike human cells, can actually survive without oxygen and in the presence of cyanide because they don't need oxygen. And so tumor cells are very glucose avid. They thrive on glucose. It's the glucose that provides the energy which drives the cancer cell. And so this becomes a fundamental concept, because if you want to then starve the cancer cell of nutrients, you starve it of glucose. It's not rocket science. This is just pretty basic biology, which we knew in 1924, that cancer cells are highly dependent on glucose. And so one of the most effective ways of killing a cancer cell is to starve it of glucose.
Wow. Yeah. And I think I had learned about this during my master's in nutrition and functional medicine training. And I was a little perplexed that people wouldn't embrace the ideal of reducing things that turn into sugar, namely carbs, in the diet to help in cancer treatment. So it's nice to kind of put that in front of people so they'll understand this concept.
Yeah. So the work of Warburg really was extended by Dr. Thomas Seyfried, who wrote the book Cancer is a Metabolic Disease. He's published multiple papers, and I think his work has definitively shown that cancer is a metabolic disease, that the genetic changes are probably secondary to the metabolic changes. Now, obviously, there are some genes which do predispose you to get cancer. For example, the BRCA gene does increase your risk. But what I actually learned yesterday, which is truly astonishing, is that chimpanzees have 98% genetic homology between humans. And chimpanzees carry the BRCA gene, but chimpanzees don't get cancer. Breast cancer has never been described in a chimpanzee, and cancer is exceedingly rare. So it goes back to the concept that this is a metabolic disease, which explains, because our genes haven't changed. So why is the incidence of cancer increasing? It's not because our genes are changing. It's because of the metabolic milieu from our environment that we work in, that we live in. And so the work of Thomas Seyfried has been revolutionary in establishing that cancer is a metabolic disease.
I love that.
Yeah,
go ahead.
And then when you think of cancer as a metabolic disease, obviously it changes your approach to how you treat cancer.
You better know it. And it also changes my look towards the horizon. So if I'm born to a family where there seems to be a genetic predisposition, and I can then impact my genetic predisposition by not activating those genes because I have a metabolically healthy life, then maybe that gives me hope that I won't have the same outcome as those family members who have maybe didn't do the same thing or didn't know how to do that. So that's really providing hope, I think.
Absolutely. You're absolutely right there, Tony. I mean, I think that's the power of understanding this, that even people who have a genetic predisposition, if they take matters in their own hand and eat live a more natural lifestyle, they can significantly reduce their risk. Yeah. And to support what I'm saying, that cancer is a metabolic disease and not a genetic disease, firstly, there's this excellent book called Tripping Over the Truth by Travis Christofferson, who basically gives a review of the history of cancer. And basically he says, and this is absolutely true, no researcher can point to any single mutation or combination of mutations and say with confidence that it alone is the cause of cancer. Nor can researchers point to a series of cellular systems rendered dysfunctional by mutations and make the same claims with confidence. And so what he's saying is absolutely true. There are some cancers in which there are no mutations. There are other cancers in which there are multiple mutations, but there are no characteristic mutations. So it seems like the genetic changes are secondary to the mitochondrial and metabolic changes. And probably the most powerful statement comes from James Watson. People may not know who James Watson is. He is Watson from Watson and Crick, who discovered DNA. He is the father of DNA. So if anybody understands DNA, it would be James Watson. And he wrote in an op-ed, we may have to turn our main focus away from decoding the genetic instructions behind cancer and towards understanding the metabolism within cancer cells. And so I think this statement is a profound statement for those people who are still hanging on to the genetic mutation theory of cancer. And then I did speak about the tumor microenvironment. So it's an interesting thing that the cancer cells live in this environment, this community, which allows them to proliferate. And there are a number of cells that are called myeloid depressor stem cells, regulatory cells, macrophages, and platelets. And so these cells conspire with the cancer cells to allow them to grow. And so this is really important in the management of cancer, because you want to get rid of these cells. At the same time, you want to embody, you want to promote, you want to stimulate the natural killer cells and cytotoxic T cells. So these are your host's immune cells. So you have these competing cells, some which are promoting the growth of cancer and others are killing the cancer cell. And just to be clear, cytotoxic chemotherapy gets rid of your T cells and your killer cells. So it depresses your immune system. So in a way, you can see why chemotherapy, while killing the cancer cells, may in the long run actually make matters worse.
No doubt about it.
And so this slide just is a graphic just depicting the tumor microenvironment, that you have these tumor cells, but they're in an environment of multiple other cells, the Treg cells, the myeloid depressor cells, the macrophages, which tend to promote their growth. And so part of the treatment is to, embolden the cytotoxic T cells, improve the cytotoxic C cells, and then get rid of the T regulatory cells and the macrophages. So to change the balance in favor of killing the tumor cells. And then there is the cancer stem cell. So this is such an important concept, and I think many people don't appreciate it. So the cancer stem cell is what is the cell that gives rise to the cancer. And it's a slow growing cell, unlike the cancer, which is rapidly growing. So when you give chemotherapy, it's like pruning the tree. You cut down the leaves, but you actually allow the roots to grow even stronger. So any form of treatment against cancer must attack the stem cells. And unfortunately, chemotherapy and radiotherapy promote the growth of the stem cells rather than killing the stem cells. And so this is just such an important concept.
It reminds me of my what I learned in my functional medicine training. And anybody that follows me on this podcast know that my acronym NEST and ROPE is all based on the root cause of why we get so-called chronic medical conditions. So the nutrition, exercise, less stress, etc., those things are the roots. And if those things are not taken care of in a proper way, the diseases are what sprouts in the tree. But it kind of reminds me that if we don't take care of the roots, we're not going to be successful. Rather, we're talking about metabolic health and my nest and rope, or we're talking about the importance of our stem cells and making sure we target them. So I think that's really insightful.
And then, as we've mentioned, most, maybe 5% of cancers are due to genetic genes. And maybe, people have a genetic inheritance. But the fact that the risk of cancer is going up, the fact that chimpanzees have the same genes that we do and don't get cancer, I think tells you the story. When I last went to the supermarket, I did, or 7-Eleven or McDonald's, there were no chimpanzees there. They have a much more natural lifestyle. So it seems that insulin resistance really underlies maybe 40% of cancers. And so this is a treatable disease. And then we have smoking, alcohol. As we said, vitamin D is so critical to preventing cancer and getting cancer. And patients with cancer, there's no question that processed foods, 80% of the foods that Western people eat are processed foods with additives, preservatives, omega-6 fatty acids, colorants, deodorize, all kinds of things. And so, there's a very strong relationship between the ingestion of processed foods and cancer. And then there's sugary drinks, which is because it causes the spike in glucose and then the spike in insulin, as we'll see. So sugary drinks and pure fruit juice. And then obviously the lack of exercise, stress reduction, and really high quality sleep. So, these are lifestyle changes that are not that difficult for people to engage in. And, the exercise doesn't have to be 3 hours in the gymnasium. It could just be a walk in the sunshine,
That's right.
for 20 minutes. That has enormous benefit.
Yeah, I plan to take a walk with my wife after we finish our recording. Sleep is critical. This again reminds me of my acronyms, because insulin resistance, the N is for nutrition, and it includes, when and how you eat. And so intermittent fasting and, maybe a keto dietary pattern are very helpful. When my rope in my acronym, the ROPE acronym, talks that the P is for pollutants. And clearly alcohol is a toxin and smoking is a toxin. So those things should be avoided. Vitamin D kind of fits under nutrition. Processed food, I would consider that under nutrition and under the P for pollutants. And that would be the same for the drinks and the juices. The E in the nest is for exercise, and the S's are for stress and sleep. So again, a reminder that being healthy is not a complex thing. It's about taking care of the basic necessities of life as listed on that slide.
Yeah, and these are simple lifestyle interventions. They're not difficult and they're not expensive, and it's accessible to anyone. And so, I thought this was a really important study. This was a peer-reviewed study published in a prestigious journal. This is a randomized controlled trial, the gold standard. And what they did is they randomized people to vitamin D, omega-3 fatty acids, or a home exercise program, singly or in combination, and then followed them up to see if they developed cancer. And remarkably, those that took the combination, as I said, vitamin D, omega-3, and a simple home exercise program, it reduced their risk of cancer by 60%. 60%. I mean, this is truly astonishing. And so, you would imagine that the news media, the press, would be interested in publicizing such an important study. No, it gets hidden. And I mean, the health benefits, our health agencies who should be promoting health, this is what they should be talking about, because these are 3 simple interventions which were proven to reduce the risk of cancer by 60%. I mean, that is exceedingly powerful.
It is. And I don't think I know anybody who would not hear this and not take these very simple steps. I was so impressed when I saw it, because those are things I do myself. But and I'm not like thinking you have to supplement yourself to help necessarily, but if you have randomized controlled trials showing the benefit, and COVID kind of taught us the importance of vitamin D. And omega-3 is something I always take because I'm more of a steak guy. So I know I don't eat enough fish. And I just think these are simple interventions, but 60% is a huge reduction.
And therefore, so following on that study, this is our, protocol for the prevention of cancer. And so, vitamin D, omega-3, green tea, melatonin, and metformin. And so I think that, the aggressiveness of the prevention depends upon your risk factors. If you are unfortunate to have a strong family history or a previous cancer, I think it makes sense to take all these supplements. If your risk is much lower, then at least vitamin D and omega-3s should be a staple. So these have all been proven. There's no question of doubt. This has been scientifically validated. So, metformin does require a prescription, but, it's exceedingly cheap. It's very safe. And so if those people who are particularly high risk, we would recommend metformin added to these supplements.
And I appreciate your tone, which is it's not one way or the highway. You have to look at your individual risk, and then you make a personal decision as to how far you want to take it. I think that's really important. I do have patients who may not be as excited about medication, but I think them knowing that there's some science to support it may at least make them aware, and then they can make their own personal decision after that awareness.
Yeah. And then, so, as you said, I reviewed over 1,200 peer-reviewed papers, and, because if you have a look, there are probably 350 to 400 repurposed drugs. And so obviously, patients can't take 300 drugs and we can't advertise them. So we had to develop some kind of a stratification or hierarchy to look at the evidence. And so we looked at, we had an objective way of looking at the data. And so we wanted studies that had clinical data, because it's all very well for a compound to kill a cancer cell in a test tube.
Right.
But, that doesn't tell us what it does in a human being. Right. So we really wanted there to be sufficient clinical data and safety data. So that's why we developed this hierarchy. So, it's important. The in vitro models and the animal models are really important as a starting point. But in order for us to, suggest or recommend these interventions, we really wanted to see, at least some evidence, some clinical evidence.
And I love the fact that you have at the top of the pyramid, the RCTs that are random, meta-analyses. And I think it's important as people look at this, that whenever possible, if you have a randomized controlled trial and you have multiple versions of that and you can do a meta-analysis, that's going to be at the highest level of evidence. Now, if you don't have that, we'll settle for those epidemiological observational studies in the scenarios like that. But whenever, and I think this is important, because so much of the confusion about nutrition and diet is based on, studies that are not as high quality. Whenever we have a randomized controlled trial, that's got to have more weight. So I really appreciate you guys really try to create that hierarchy so that the evidence will mean something to those who consume it.
And what is surprising is that for many of the drugs, there was high quality evidence that is out there. It's just somewhat hidden, but the studies are there. Yeah. And then obviously the other concept is that if the only tool you have is a hammer, the world looks like a nail.
Right.
And so you know what I'm talking about. So, if you go to an oncologist, they're going to give you chemotherapy.
That's right.
If you go to a surgeon, they're going to operate. So you really have to be able to look at the data objectively, without any preconceived bias.
And that's why it's a grassroots effort to get this information out. And that's why I said earlier that if a patient wants to share this with their clinician, they should, or a family member, because the family member or the clinician may only have one tool or two tools in their toolkit. They now open up the world to a broader perspective, which is what happened to me when I got my training in obesity medicine, when I got my training in nutrition and functional medicine. My toolkit expanded, and it really opened my eyes to things I didn't even know existed.
And then, so, what we did is we ranked the top 20 interventions for cancer, but it's really the top 10 that I think are so important. And so these are interventions to control cancer. And the first, obviously, is a low carb, high fat ketogenic diet, time restricted eating. Because as we said, the cancer cell feeds on glucose. Cancer cells actually cannot use ketones. In fact, ketones are toxic to them. So there's overwhelming data. I mean, this is not made up, that, dietary manipulation and a low carb diet really makes a difference. And then we have green tea, melatonin, vitamin D. You can see metformin. You can see, again, so if a compound is really effective in preventing cancer, it works on those cancer preventing pathways, it's sure likely going to be useful if you actually have cancer. So it's just goes to show. Metformin, and then curcumin, or which is an Indian spice that's available and is a nanocurcumin, which is much better absorbed, has enormous biological property. It has many different pathways. It really is a phenomenal compound, and it seems very effective for cancer. And I should add that we're not using one therapy. So, we would never advise curcumin on its own, but really a combination of these interventions which act additively. And then mebendazole, which is an antiparasitic drug. It just so happens that antiparasitic drugs are really quite effective against cancer, maybe because cancer is in a way a parasite. So mebendazole acts both on glucose and glutamine by depriving the cell of those, but it also interferes with cell division, as well as it promotes cell death. So it's a highly effective drug against cancer. And then again, omega-3 fatty acids, berberine, and exercise. Exercise, believe it or not, really, if people, embark on a program of, aerobic and anaerobic exercise, it actually improves their longevity, improves their quality of life. It has enormous health benefits in people with cancer.
Yeah, and it makes sense. I've always shared with my audience that, muscle mass is important so you won't fall and break your hip one day. But, if we don't move our bodies, we're going to struggle. And more importantly, although in some ways we think about longevity when we think about cancer, the quality of your life is so much better if you can actually play with the grandkids or the great grandkids and chase them and get on your knees and maybe, go on a hike with them as opposed to, being pushed around in a wheelchair. So I think that's really amazing.
Yeah, so it's really the quality of life which we need to focus on. And so again, coming back to the Warburg phenomenon, just to make this point, because most oncologists think that diet plays no role in cancer, which is truly astonishing. A patient told me 2 days ago, she asked her oncologist, he said, you can eat whatever you want, milkshakes, candies, chocolate, that diet makes no difference. And obviously, as I will show you in this slide and the next slide, that's just so completely false. So normal cells use glucose. Cancer cells cannot use glucose anaerobically. So they have a mitochondrial problem. So the glucose goes to pyruvate and lactate, and they cannot use aerobic metabolism to generate energy. And this is a characteristic of all cancer cells. And so based on this, Jane McLennan, who she had stage 4 cervical cancer, and she was told, there was nothing more that could be done. And she decided she wasn't going to accept that. So she came up with a plan similar to what I've been describing to starve her cancer. And then, Dr. Ziefried's book. So again, very good evidence that cancer is a metabolic disease, and you need to starve the cancer cell. And so this is the problem. If you have, high carbohydrate food, processed foods with a high glycemic index, You get a high blood glucose. The high blood glucose fuels and provides energy for the cancer cell. At the same time, it causes a release of insulin, and insulin causes the growth of the cancer cell. It potentiates the growth, potentiates the tumor microenvironment. So the combination of high glucose, high insulin is the worst combination for controlling cancer. And so, I think it's well illustrated in this peer-reviewed publication. So this is published in the Journal of the National Cancer Institute. So this is a highly prestigious, reputable medical oncology journal. And what they were looking at is to see if dietary insulin load and cancer recurrence affects survival in patients with stage 3 cancer. So basically what they concluded is patients with resected stage 3 cancer who consumed a high insulinogenic diet, so it's a diet high in glucose, high in insulin, had an increased risk of recurrence and an increased risk of mortality. So this is data from one of the most prestigious oncology journals, basically supporting and validating what we've been saying, is that dietary manipulation and dietary control is such a critical part of the management of patients with cancer. So chemotherapy does have its role, which we'll talk about briefly. There are many different chemotherapeutic drugs. These act only on the actively dividing cells. And so chemo fails for many reasons. As we've already said at the beginning, tumors are composed of a heterogeneous population of cells, many of which are slow growing. And the chemo will only act on those cells that are actively dividing, as most of the tumor cells are actually in the rest phase. Only about 10% are in the cell cycle phase. And chemotherapy doesn't improve the microenvironment, which is so important. It, in fact, makes it worse. It enhances rather than kills the stem cells. And with time, many of the cancer cells become resistant. So it's not surprising that chemo often fails. So if you compare or contrast chemo with repurposed drugs, you can see significant differences between them. Repurposed drugs act on all the cancer cells. They act on the suppressors, the stem cells. They enhance the immunity, which is really important, whereas chemo suppresses your immunity, improves the microenvironment. And then chemo is very toxic. It's myelotoxic to the bone marrow, causes severe immune paresis and immune impairment, severe toxicity and systemic side effects. And then, of course, the costs are astronomical compared to repurposed drugs.
Yeah, that's an understatement.
So, when one thinks of cancer and chemotherapy, it's important to understand this concept that there are a small percentage of cancers that are curable with chemotherapy, about 5% of cancers. So these are choriocarcinoma, the leukemias, testicular cancer, much like Lance Armstrong had, Hodgkin's, non-Hodgkin's lymphoma. So there are a group, about 5% of cancers in which chemo is curable. So obviously we would not say don't take chemo in these patients, but we would obviously suggest that they follow metabolic protocol, use repurposed drugs, because we know that they act synergistically. So the chance of a cure is even higher. There are a group of cancers in which once it's metastatic, it's not curable. But what chemo can do is slightly prolong, life's duration of life or disease-free interval. So it does have a small role in prolonging survival. And then there are those cancers in which chemotherapy really has minimal role in improving quality of life or improving survival. We're talking about colorectal, pancreatic, esophageal, hepatic, kidney, prostate. So it's important when one thinks of cancer that what's important is the type of cancer, the stage of the cancer, and then the patient's comorbidities. And then based on that, you develop a personalized approach to cancer.
I think as I look at this, and I'm somewhat shocked at the ones that provide palliation only, I want to bring up the concept of palliative care versus hospice. And so many people who are being treated for cancer never have a conversation with a palliative care or hospice type clinician. And it's really important to understand that the palliative care path is really one to really support the family and the patient. And you don't even have to have a incurable medical condition to take advantage of that. So if you're looking for that comes to mind dealt with lung cancer, people who do palliation while treating their lung cancer, even if it's with chemo, live longer than people who don't. And then when you think about hospice, you think about maybe they're anticipating no more than 6 months to live. And that's more, instead of, support, it's more comfort care. And in that setting, you'll get more resources, but you'll be getting the kind of comfort care you and your family need. So I think it's so important as you talk to your family member who's going through this, had they ever brought up palliative care? Had they ever talked to you about it? You can get the goals of care taken care of doing that type of conversation. Sometimes they're better at treating your pain than the primary care doc or even a hematology oncologist. So I just wanted to put that out there, that's something we all should take advantage of, no matter how you plan to approach your diagnosis.
Absolutely. And then, so, I think as you've discussed, there are many different options. It needs to be personalized based on the patient's own, beliefs and wishes. But, I think the role of repurposed drugs and chemotherapy depends upon the type of cancer. And
Yeah.
so, as you see, repurposed drugs have a role in all stages. Chemotherapy, as the disease becomes less chemo responsive, chemotherapy doesn't improve the quality of life. And, many patients die of the therapy rather than of the disease. And, that's the tragedy.
And that's kind of why I brought that up, Doc. This idea of palliative and hospice. If a patient's not given clear expectations on what the goal of care is, and when you think about, if we go back a little bit and we think about these palliative conditions only, right? Well, if I have a condition that's only providing palliation and I'm thinking it's curing me, then that's unfair to me. I think I need to be given the option of, if I do this type of treatment and it's not curing me, do I really want to go through that? And some people may say yes, if I'm expected to live 6 months and that gives me 7 months, that extra month may mean something to me, even if I have to go through the discomfort of chemo. But other people may say, you know what? I don't want to do that. Give me my 6 months. I'm going to travel to Paris. I'm going to go to New Orleans, and I'm going to enjoy my life without the side effects. And that's why it's important to have these conversations that your clinician may not have suggested, but I want you to suggest it next time you or your family member are faced with a discussion like that.
Yeah, I mean, I can't agree with you more strongly that, it has to be a personal discussion. I think it has to be truthful. The oncologist has to truthfully tell the patient, what to anticipate, with the quality of life. And some patients may want that extra month. Others,
That's
as
right.
you say, may say, you know what, quality of life is much more important to me. I'm going to follow a different path. But at least patients should be told the truth.
That's right.
The truth is important, and given the choice, they're the ones with the disease.
That's right.
And so, just finishing up, there are some cancers that are curable with surgery. So these are, patients who present with stage 1 disease, so it's localized to the organ. And as you can see, if it's a localized disease which can be surgically removed, this 5-year survival is really good. So surgery does have a role. Chemotherapy does have a role. But I think one has to put it in the correct perspective.
Love it.
So just to finalize, it has to be personalized. Management has to be personalized based on the patient's wishes, desires, expectations, the kind of cancer they have, the stage. And then it's a combination of repurposed drugs and metabolic therapy, chemotherapy, surgery, and then general management. And that, there's absolutely, I think it's horrendous that patients get chemotherapy without consideration of any of these other treatment modalities. I think that's just doing the patient a profound disservice.
And I know there's it's resource intensive for a health system to think about this. I know it's resource intensive for insurers to understand the value of this, but the same thing that allows certain cultures to live longer than others, what you'll find is that if you think about the blue zones, and let's just say those folk may be living better because they're eating a clean plant-based diet, and then you think about Hong Kong, they eat 2 steaks per person per day, and the Mormons, they eat a lot of meat and they live long. So the question is, what is it? It's all this other stuff. It's the social connections. It's the having love and support. It's being able to get out with nature. It's being able to move your body. It's those other things that we do that may impact our longevity just as much as the things that you think are important. So I really think it's important you think big picture. What are the things that I'm struggling in? Do I know how to get enough sleep? And if the answer is no, maybe I'll work on sleep this year. And then after I work on sleep in 2023, then maybe in 2024, I'll work on how to reduce stress. And then ultimately, you'll create a body that's metabolically healthy, that when faced with the challenge, maybe you were exposed to some toxin in your life, your body will be in a better position to fight it.
So, Tony, I want to thank you for giving me this opportunity to have this discussion. If folks are interested in downloading the monograph and the PowerPoint, it's available free of charge. They can go to our website, flccc.net. Under the menu, medical evidence, they will see the monograph and they can download it for free. The good news is that we will be having this monograph available on Amazon as a Kindle and as a book. So within the coming months, hopefully, for people who actually like to have something in their hand to hold, we will have a book.
Yeah, I love that. And I really appreciate that. And we thank you for, just walking through that. First podcast done as a presentation, and it's an honor that Dr. Paul was the one who provided that. And I really thank you for that. So when it comes to big picture for you, when you think about, what you're hoping to do over the next, year to protect your nest. I wonder if I just noticed there was like a little something on my face the whole time, but the nest really speaks to nutrition, and intermittent fasting and keto is kind of where we live, and people can do what's best for them. The E is for exercise. S is for less stress, more sleep. The T is for recovering from trauma and or making sure your thoughts serve you. The rope to climb up to the nest talks about positive relationships. Like I said, I'll be taking a walk with my wife when we're done. Can't wait to do that. Hear about her day. She'll hear about me and you chatting today. Avoiding organisms and pollutants that harm you, whether that's the water we drink, the air we breathe, food we eat. And then, of course, the E is about making sure our life experiences service and making sure our emotions are protected. So when you think about your next 12 months, Dr. Marik, where do you think you're going to give additional attention over the next year?
Wow. I like the acronym because I think they're all just so important. They all interact. There's no question that you have to deal with emotional well-being. You have to deal with, social well-being. You have to deal with emotional well-being. You need to deal with metabolic therapy. So they're all interconnected, and it's really a lifestyle change. This is not a diet. This is a lifestyle change. And I think people need to, they can empower themselves. This is something that's not difficult to do. Intermittent fasting is not a difficult thing to do. Eating good food is not a difficult thing to do. Taking care of their mental health is something that's important. So I think this is a major shift in the way we practice medicine, but it's just so important. And, I think the benefits can be enormous. And of course, the cost saving, because all of these interventions are just so exceedingly cheap or inexpensive. So it should save our country, the healthcare system, enormous amounts of money.
Yeah, I agree. And I just, again, my vision is that, I'm a realist. I know politicians are influenced by lobbyists and special interests. I understand how the dietary guidelines are written, and they're not always evidence-based. So I understand that's the reality. But my vision and my true north is that one day, because we're going to keep fighting, is that we'll live in a world where people are making decisions that serve people for the right reason, as opposed to politics, money, and things like that. But again, we appreciate the work you're doing. We're going to make sure to share the links to those great resources. And we did a video short that kind of focused on the prevention and treatment, because that's so important. So for those who are watching this, at the minimum, make sure you pay attention to the slide that talked about the 5 things for prevention if you are trying to prevent cancer, and the 10 things to think about if you have cancer. And again, I thank you so much. And I'm going to conclude with a couple of comments as we wrap up. And again, guys, it was a privilege to have Dr. Marik present a nice presentation, so that when you get to those slides, you'll be able to kind of walk through them whenever you want to. And now we know that, yes, there are some conventional things that we do, but man, if we use these natural approaches, including repurposed medications, that would be a great gift to someone who's struggling, particularly someone who's been told, we can't do anything else for you. How about if we give them an additional tool so that they can fight this fight with more weapons in their hand? And I just think this information empowers us to think outside the box and to have the courage to have a collaborative discussion with our clinicians. And again, this may be the source you share with them. So make sure to share this resource with friends and family. Make sure you think outside the box if you're not already doing that. And I just appreciate you guys for just caring enough to get to this point of the podcast and to still be chiming in, listening in. If you have thoughts or questions, throw them in the comments, and we'll try to make sure anything that you share, we circle back and get that answered as well. So I thank you for coming to this episode of the Protecting Your Nest podcast. And until the next episode, continue to be safe, be well, and continue to protect your nest. You've been listening to Protecting Your Nest with Dr. Tony Hampton. For more, visit drtonyhampton.com.